Pacritinib is a JAK2, FLT3, and IRAK1 and now ACVR1 inhibitor. So 4 targets at least. So JAK2, FLT3 not as relevant to myelofibrosis, but ACVR1 is something of great interest with regards to anemia, and then also IRAK1, which is important in the inflammatory signaling in this disease. Pacritinib was approved by the FDA on February 28, 2022, so about a year and a half ago, for patients with myelofibrosis and severe thrombocytopenia, so less than 50,000 platelets. However, what's important to appreciate is that this drug has really been studied across the cytopenic spectrum. Now, its approval may seem relatively narrow, but the drug has been studied in patients across the range of platelet values and hemoglobin values, and there was a recent analysis done to sort of look at patients across the cytopenic spectrum, stratify them by the degree of anemia or thrombocytopenia, and really look at pacritinib's performance across those ranges of blood counts. Now, pacritinib is justifiably regarded as being particularly good for cytopenic patients, and I think the data does speak to that. But when you look at all the 3 major trials that were done, PERSIST-1 was in patients who were JAK inhibitor naive, and this had really no stipulation on platelet count. PERSIST-2 was done in patients with 100 or lower platelets, and patients could be JAK inhibitor naive or JAK inhibitor exposed. And then PAC-203 again did not have a platelet count stipulation, but all patients had to have been exposed to a prior JAK inhibitor. So when you look at all these trials together, you're looking at somewhere in the range of 600 to 800 patients that pacritinib has been studied in at different doses. Now, the approved dose is 200 milligrams twice a day. And so coming back to the analysis that was done of the different cytopenic strata, if you will, what was found was that pacritinib it certainly works across the range of cytopenias, whether it's spleen or symptoms. And in fact, a signal that was noted was that the symptom benefit really seemed most pronounced in the patients with the most severe anemia, which sort of brings us to another interesting discovery from last year about pacritinib, which was to show that it's a potent inhibitor of ACVR1, as I alluded to earlier. Now, when you block ACVR1, you reduce hepcidin production from the liver, and if you do that, you make iron more available for erythropoiesis, and therefore you ameliorate anemia. Now, this is of course theoretical, and was shown in the lab that pacritinib was a very strong, potent inhibitor of ACVR1, but also in the clinical trials, when they went back and looked at the anemia benefit of pacritinib in PERSIST-2, the pivotal trial, they looked at patients who were not transfusion independent, and they looked at the conversion of those patients to transfusion independence. And depending on which criteria you used for defining transfusion independence, you saw anywhere from a 25% to a 37% rate of transfusion independence conversion for pacritinib, and it was way lower for the BAT, which did include ruxolitinib at low doses. So I think the pacritinib story has really evolved from one that may have been viewed as a drug only for patients with very low platelets to a drug that really works across the cytopenic spectrum and helps anemia.